Welcome to Taking Charge of Your ILD in Myositis with MSU and Dr. Cheilonda Johnson. My name is Jerry Williams, and I'm a patient living with dermatomyositis, and I'm also the founder and president of Myositis Support and Understanding, which is an all-volunteer, all-virtual, patient-centered nonprofit organization working to improve the lives of those fighting myositis. Also with me today from MSU are Lynn Wilson, the Vice President, and Manuel Lubinis, the Patient-Centered Research Advisor. Privileged to welcome Dr. Cheilonda Johnson. She's an Assistant Professor of Pulmonary Medicine at the Pulmonary Medicine at the Hospital of the University of Pennsylvania. And she is board certified in clinical care medicine and pulmonary disease and works with many patients, not only with lung disease but lung disease that's associated with myositis. So we're so excited to have you with us today, Dr. Johnson, and just like to welcome you. And if there's anything that you would like to add about yourself, we would love to get to know you, and thank you.
So thank you so much, Jerry, for that kind introduction. Yeah, that bio is pretty accurate. I'll just say that I'm a specialist in interstitial lung disease. I've been practicing in ILD for the past 8 years, and I have a research focus on patients who have autoimmune-associated ILD, and that is primarily in patients with myositis. And so I have 3 active clinical studies right now, and 2 of them are in patients with myositis. And so I spend a lot of time thinking about ILD and a lot of time thinking about patients specifically who have myositis and ILD. I really wanted to spend the beginning part of this session going through some of the frequently asked questions that I received. I think that this will set the stage nicely for all of your questions, but please do not let me go through the entire session. If you have questions, I'm happy to be interrupted and answer along the way. But I've also made sure I left plenty of time at the end to answer any questions that come up during the session. And so I'm going to start just with some basics, and I apologize if you heard this all before. And so I really enjoy this quote. This is a quote that came from a study that some of my colleagues did a few years ago, where they surveyed patients who have ILD and their family members. And I think that this quote really sums up a sentiment that I hear quite frequently from my patients, which is that they really have a hard time explaining their condition to their friends and family. And you all might experience that doubly so, because if you have myositis, you also probably have a hard time explaining what that is to your family and friends. And I think that there are several reasons why this is a really challenging topic for patients. I think that firstly, it can be really difficult to conceptualize this if you don't spend a lot of time thinking about lung anatomy, which most of you probably do not. And also, I think that as practitioners, we probably do not do the best job of explaining exactly what ILD is. And so this is going to be my best attempt. I found this graphic online, and I think it's really fantastic. And so I'm giving credit to the ILD Collaborative, which is where I found it. But this really mirrors a picture that I will draw frequently for my patients when I see them in clinic. And so if you look at the panel here on the left, you have your windpipe or trachea, and that branches right and left. And then each of those major airways branch smaller until they end in an air sac, which is the alveoli. And so it's really at the level of the air sac where you get oxygen transfer from your lungs to your bloodstream. And remember, oxygen is like our body's fuel, right? It's our gasoline. And so it's the space which is drawn here in blue between the air sac and the blood vessel. That's the interstitium. And so that's the part of the lung that, if you have interstitial lung disease, becomes either inflamed or scarred or both. And so they've drawn in a very nice blow up here, a schematic that shows the edge of the air sac, the interstitium with scarring and inflammation, depicted here as a green bar, and then these little blue fibers, and then the blood vessel. And so this is very different than diseases that affect the airway. So things like COPD or asthma. This is a completely different part of the lung. And so as you can imagine, those conditions that affect the airways will be different than the things that we use to treat things that affect the interstitium. And just looking at the schematic, it gives you some sense of the problems that patients can have, which is that these little air sacs can't fully expand if they're surrounded by inflammation and scarring. And if you have enough inflammation and scarring, you're going to have difficulty getting oxygen from your lungs to your bloodstream. And so this is what ILD is. Another reason why I think patients get very confused, and quite frankly, physicians as well, is that ILD really is an umbrella term for over 200 different conditions. And so when we think about classifying ILD, we try to simplify it by grouping all of those 200 conditions into 4 big bags. And it's really not important for you to remember these 4 big bags, just kind of to understand that there's a lot of variability in this condition. And there's a lot of conditions that are called ILD that are going to be very different than the ILD that a patient who has myositis has. And so among the unknown causes or unknown ILDs, the most common is idiopathic pulmonary fibrosis. And I mention this here because I know a lot of patients know a lot about IPF, because when you Google ILD, IPF is going to be one of the conditions that comes up because it's one of the more common types of ILD. But this is very different than some known types of ILD, which include the autoimmune associated ILDs under which myositis occurs. And so these are 2 distinct disorders that are classified differently and treated differently. And then there's the granulomatous diseases, which includes things like sarcoidosis, which I listed here because some of you may have heard of. And then there's everything else, right, that go into the little miscellaneous bag. And so this causes confusion because I think that people find information about one type of ILD that probably does not apply to them. And so this aids in the confusion. And so we know that patients who have autoimmune conditions, not just myositis, are at higher risk for developing ILD. And it's not entirely clear to us why that is the case. And depending on the type of underlying autoimmune condition you have, your risk for ILD will be different, which I've depicted here based on the size of the circle. And so as you can see, myositis is one of the larger circles here because we know that patients with some forms of myositis are at higher risk of developing ILD. And this is different than some other conditions like SLE here, which is the abbreviation for lupus, where true ILD is actually quite uncommon. And it's also important to note that some patients will not cleanly fit into any of these circles. And so there are some patients who have overlapping syndromes, and that might apply to some of you where you may have features of myositis, but you also may have features that are more typical of other types of autoimmune disorders. And some of the common overlaps we see with myositis are scleroderma overlaps and Sjogren's overlap syndromes. And so what we know, though, is that not all patients with myositis are the same, which I'm sure you guys have appreciated by now, and that the risk for ILD is also not the same for all patients who have myositis. And so any patient with myositis can have ILD. And so I don't think that you should think that just because you have a specific diagnosis that you have no risk. But there certainly are some types of myositis where the risk for ILD is lower than others. And so the conditions in which we most commonly see associated ILD would be dermatomyositis, polymyositis, and antisynthetase syndrome. And it's pretty uncommon for people who have inclusion body myositis to have ILD, or patients who have necrotizing autoimmune myositis to have ILD, but we certainly have seen rare cases of that. And then in the circles depicted below, I've listed some of the more common antibodies that we see with ILD patients. And so just to remind you guys, the antibodies are the proteins that we can measure in the blood that generally our bodies are making to protect us from external infections, but sometimes can be directed against parts of our body. And so we're learning a lot about these antibodies that we see in patients with myositis. And quite frankly, 15 or 20 years ago, a lot of these antibodies had not even yet been described. And so there was no way for us to measure them. But as we learn more, these are the antibody tests that we're frequently sending in our patients with myositis, and we've seen some clear patterns. And so the antibodies listed in blue are the antibodies that we see most commonly in patients who have ILD. And the first 5 listed here are all in the same group of antibodies that are anti-synthetases. And this can fall into patients who have anti-synthetase syndrome, which is a type of myositis that's highly associated with having ILD, as is MDA5. And then the antibodies depicted here on the left, we see less commonly in patients with ILD, but I certainly do have patients who have all of these antibodies who have had ILD. So again, your risk is not 0, but much smaller. And so next I'm going to...
Johnson.
Sure.
Barbara asks, could you explain cellular NSIP?
Mm-hmm.
I'm not sure what that is myself. Do you know what she's referring to?
I do, yeah.
Great. I'm like, I don't know that. I don't know that one.
So when we, maybe I can answer this question in a later slide, but I'll just say briefly that this is a certain pattern of injury that we see on a CAT scan. And so this is referring to a type of pattern that we can see in patients with ILD. But I will get back to that when it kind of fits in with the conversation. Is that okay?
That's perfect. Thank you.
Okay. And so to change gears, let's talk a little bit about the presentation and what we look for. And so typically I'm going to see patients in one of 3 categories. I'm going to see patients who are presenting for the first time with shortness of breath, who do not have a known diagnosis. I'm going to be seeing patients who have a new diagnosis of ILD, but we don't know what the cause of their ILD is yet. Or I'm going to be seeing patients who have a known diagnosis of myositis where the provider is concerned about whether or not that patient may have ILD. And so my approach to each of those patients will be a little bit different, but the things that I'm going to look for are going to be certain historical features. And so the most common symptom that patients with ILD have is shortness of breath. And if you remember the little graphic that I showed you of what ILD is, you can imagine that if you have your air sacs that are not able to expand, that when you need to increase your lung capacity during exercise, you're going to have more difficulty breathing. And so most patients, at least initially in the disease, do not have any symptoms when they're at rest, so sitting on the couch per se, but will get symptomatic when they get up to exert themselves, and usually with pretty heavy exertion at first. So going up the stairs, carrying or lifting something heavy, they'll notice that they start to have shortness of breath. And a lot of patients may initially discount these symptoms as aging or being out of shape, which certainly can cause shortness of breath. And so they may wait to present until it becomes a more noticeable symptom for them. But shortness of breath with exertion is one of the first presenting symptoms. And typically the more fit a person is or the more active they are, the earlier they're going to notice these symptom changes. So someone who's very sedentary may not present until they have very late stage disease because they're not going to experience these symptoms because they're not up and moving around very much. The second most common, go ahead.
Sorry, would this stage be like at a point where just talking can make you short of breath?
So certainly I do have patients who are short of breath when they speak. And if you think about it, speaking can be quite exertional. Typically, this is going to be people who do a lot of speaking though. So I'll have patients who say, you know, I have to give meetings and a conference call, and I get halfway through the call and I start getting very breathless. And so speaking is definitely exertional. You would have to lose a lot of lung capacity before, you know, just casual conversation would make you short of breath. But definitely people will be short of breath when they speak, particularly if they speak a lot.
Great, thank you.
Mm-hmm. And so the second symptom I was mentioning that a lot of people experience is a cough. And the cough that is associated with ILD tends to be a dry cough. And so people are generally not going to cough up sputum or phlegm. But sometimes people will. And the cough can actually be sometimes the more problematic symptom for people. The cough might be something they notice first, or their family members will complain about. And so sometimes cough may be the only presenting symptom. And then, of course, there are the symptoms that are specific to the myositis that might come up as well. But in terms of the specifically ILD symptoms, these are some of the ones that we look for. When we examine patients, depending on the type of ILD they have or how advanced it is, we may hear extra sounds when we listen to the lungs, particularly at the bottom of the lungs. And so you may hear your doctor use a term called crackles, which is hard to describe, but what it sounds like when you listen is like someone pulling open Velcro. And so that's the sound of crackles. And we can oftentimes hear that in the lungs of patients who have scarring in their lungs. And then sometimes, go ahead, I'm sorry.
Would that be the type of feeling that you might have if you've ever had like bronchitis or?
No, so, bronchitis is going to be inflammation of the airways. And so some people who have bronchitis may describe feeling tightness in their chest. They certainly may be short of breath. If they have a cough with bronchitis, they usually will be coughing up phlegm. And when we listen to the lungs of someone who has a bronchitis, we hear something called bronchial sound, which is kind of like a loud pitch, kind of like whistly sound. We can kind of hear the air trying to go past those inflamed airways and areas in the airways where there might be partial blockage with mucus. And so that sounds very different than the crackle sound does.
So, yeah, so when you're listening to somebody's lungs, right, can you hear, that's what you hear, or are these the symptoms more that the patients are?
No, these are things that the doctor may hear. And so,
such an art to that, right? Such an art to the listening with the different, I imagine it must have been hard to learn. And then, all of the training, with your fellows afterwards, it's just so interesting.
I think so. I mean, it's very subjective, right? And so again, we use terms like that's what we've always been told is the sound of someone pulling open Velcro, but maybe someone doesn't really know what that sounds like. And so a lot of it's just kind of like pattern recognition, like you hear it a certain number of times, you're like, okay, this is what crackles sounds like to me. But yeah, you do kind of get used to listening to these sounds. And so I think that sometimes the patient may not feel like we're really listening for much. You kind of like come in with what's okay, but we're actually listening for very specific types of sounds. And quite frankly, I mean, there has been some lost art to the physical exam with the use of imaging in a lot of patients where you're going to get that anyway, but you can oftentimes learn a lot about what's going on in someone's lungs just by listening very carefully.
Thank you. I love hearing the art of medicine, when you start doing these things that aren't just, black and white. There's not a test to just, so thank you for sharing that.
Sure. And then clubbing is a change in the tips of the finger, and it's due to changes in the curvature of the nail bed that can happen due to a variety of conditions, but one of those is from having chronic lung disease. And so we'll look closely at the fingers for that as well. And then of course, because I see patients with myositis, I'm not just looking for clubbing, I'm looking for signs and symptoms of myositis. So those kind of classic myositis rashes, Gottron's papules. I'm looking at your joints to see if your joints are swollen. I'm looking around your nail bed to see if I see redness around the nail bed. So there's lots of clues that can happen in the hands as well when you're trying to see if you think a patient may have ILD, and particularly an ILD that's related to an autoimmune disease. And then if I'm really suspicious at that point in time, or I may have information that another provider may have already ordered, I'm going to take a look at your blood test and see if there are signs of inflammation. So that would be things like a sedimentation rate, or something called a C-reactive protein level, or if I'm lucky enough to have it already sent, I'll look for antibody levels, or I'll send for the antibodies myself. And so these are going to be the things that we're featuring in when we first see a patient, are their history, what we see on their exam, and then what we know about their blood tests. And so
And I think if I could, I think it's just, it highlights the fact that, you know, there's a lot of times where ILD is the presenting part of the myositis, right? Where there's no muscle involvement at the moment. There might be limited skin involvement, but it's, the primary is this ILD, right? Do you see
that's
a
right. And so I think that, that's been an important part of the awareness, is just making sure that all providers who may encounter a patient with myositis are familiar with the disorder. And so, as you all know, this is a systemic disease. It affects multiple parts of the body, the muscles, the joints, the skin, the lungs. And so how your initial evaluation goes really depends on which provider you see first. And so if you come into the hospital and you're very sick, and you end up in the ICU and you have inflammation in the lungs, the ICU provider has to be thinking, well, this inflammation in the lungs could be a pneumonia, but it also could be the presenting signs and symptoms of a patient who has an autoimmune disease like myositis. And so, again, it's really a big campaign towards getting everyone informed so they know to look for this, because if you don't look for it, you're not going to understand what you're treating. And so a lot of times the issue with patients with myositis is not that we don't know what to do, is that there is a long delay in people doing the right thing because they're not thinking about myositis until very far down the road when they've excluded everything else. And at that point, there's already been a lot of damage done. And so, I'm trained to think that way, where I'm looking for these things as a part of my routine evaluation. And so, as I mentioned, I'm looking at patients' skin, I'm looking at their hands, I'm asking them about their strength, but not every lung doctor in the community is going to do those things. And so now I'm going to talk about the next kind of step in the evaluation that would be specific to what the lung doctor might do. And so we love pulmonary function tests. These are breathing tests where we have patients do breathing maneuvers, so blowing in and out of a tube that's placed in the mouth. And so I have two examples pictured here. And we do that while the nose is clipped so that we don't have any place for air to escape in or out. And we do these tests for a variety of reasons. The first reason is just to see, is the lung function normal or abnormal? And so when we look at lung function tests, we really can group patients into one of two categories. Do they have a problem getting their lungs to expand, or do they have a problem getting air in and out of their airways? And so that's kind of a big classification of patients. But the second reason why it's helpful to get these, and to get these pretty early on in someone who is exhibiting symptoms, is to establish where that patient is starting from. And so I'll share an anecdote with you. I just saw a patient in clinic last week. They had lung function tests done in October, and then they had them done when I saw them last week. And so the lung function tests they had done last week were actually only mildly reduced. And so had that been the very first set of lung function tests, the answer would have been, well, you have some abnormality, but it's pretty mild. But that patient had those prior lung function tests, and I was able to see that they actually had a 30% decline in their lung function in between that first test and the second test. And so even though that second test was not bad as an isolated test, overall, it was showing that there was significant progression of that individual's lung disease. And so having a baseline for comparison is so key. And it's so helpful when that is done early on, because that really gives us a lot of information, and gave me information that allows me to act quickly in that patient, because even though they only had a mild reduction based on what we consider quote unquote normal, they were very far from their own individual baseline. And this really is, go ahead, I'm sorry.
I was just going to ask, for those who, you showed that nice slide of, the risks of, based on types of myositis. For those who might not be testing positive for any of the myositis autoantibodies, but have been diagnosed, say, with one of the, PMDM or antisynthetase, do you think that they should have maybe see a pulmonologist even if they're not experiencing symptoms, or should maybe ask for their rheumatologist or neurologist to order a set to have as a baseline? Because that's, it's remarkable that you were able to have that and act, so I was just wondering if you have any advice on that. I know it's not medical advice, but if you
Yeah,
could.
so I mean, I think it's so, this is definitely just my opinion. We do not have good data to guide us any way or another about how to screen patients. I think this is a big area of research that needs to be conducted, which is, do getting early lung function tests in patients who are at risk without symptoms, does that change outcomes? My personal opinion is that I think that it would. And so I do think that in someone who has a high risk antibody or condition who's asymptomatic, that getting a baseline set of lung function tests is helpful. Where it becomes challenging is, that can be hard to get someone's insurance to pay for. And so you might have to finagle things to just present a symptom so that there's a justification for doing it. But I do find that it's very helpful to have had that information about someone's baseline when they develop symptoms later on. And then part of it just being very vigilant about people having even very mild symptoms, asking them the questions and then getting them in timely. But in my personal opinion, I don't think that every patient that has myositis should have lung function testing if they're not symptomatic. I do think patients who are at higher risk for developing ILD would benefit from having just a baseline set of lung function tests.
That's so great. Thank you for that opinion. I was going to say advice. No, not advice.
Yes,
opinion.
that is my opinion. That's
Yeah.
right.
Yes, and it's valued. We appreciate it. We do have a question, Kim. What does it mean if your lung function test keeps decreasing or declining? And that might be coming up in your slides, but I wanted to go ahead and ask that.
No, I think it's a perfect question for now. And so, as I was going to say, part of why we do this too is because this is one of the main tools that we use to follow patients over time. And so a patient who's got a continual decline in their lung function, that's telling that their ILD is active and progressing. And so we tend to do these every 3 months or so when we first diagnose a patient, or if we think a patient has active disease. Once someone's lung function stabilizes and they don't have signs of active disease, we can do them less frequently. And the reason is exactly why this person who asked the question mentioned it, is that if we see continued decline, we know that what we're doing is not working and that we need to make an adjustment to our treatment. And so this is our main way of monitoring for progression and success of our treatment. And so good outcomes with lung function is to see a stabilization of lung function over time, or in the best case scenario, improvement in lung function. But continuing declining lung function without an alternative explanation generally means that the lung disease is active. Sometimes there are things that are not someone's ILD that would cause them to have a decline in their lung function, but generally someone who has a known ILD whose lung function continues to decline is usually because their lung disease is active. And so in those patients, we're going to usually do other studies to confirm that the ILD is what's active. And so I'll get to it in a second, but imaging of the lungs, and then sometimes if we're worried about a secondary process, we might get additional testing of the lungs to make sure that what's driving it is really the ILD. But in most circumstances, that is the patient's ILD being active.
Thank you for that. I love the answer. It was very well explained. Thank you so much.
Mm-hmm. And so the next part of the evaluation is going to be to get a picture of the lungs. And so you can start with a chest X-ray. It's not the preferred way, however, of looking at the lungs in a patient that you suspect has ILD. And so I show here, and it's not important to take in what's pictured here, but just this is an example of a patient who has pretty advanced case of ILD. And so it's pretty apparent here, but a lot of our patients early on, it's not going to be this striking on a chest x-ray. And so the actual preferred way to image patients who we think has ILD is to get what we call a high resolution chest CT or chest CAT scan. And what that means is basically it's designed to get the thinnest cuts of the lung that allows us to be able to get the best picture quality of the lung tissue itself. And so this is a CAT scan that's done without giving contrast, so there's no IV dye given to the patient, and it's a particular protocol the radiologist does. And this is the preferred way of looking for ILD. And so a lot of times we will have patients that come to us from the community who have had a chest CT that's not really the best quality, and it's because it's not done in this protocol. So it's a very specific high resolution chest CT scan. And so I did not forget about our patient who asked the question about cellular NSIP. And so when we look at a CAT scan, the radiologist is going to use certain terminology. And the reason why they do is because that terminology helps us think about those 200 conditions I mentioned that fall into that umbrella term of ILD and figure out or narrow down what we think might be causing that. And so of those conditions, certain types of ILD are more likely to give you a specific pattern on the CAT scan than others. And so what cellular NSIP means is that so non-specific interstitial pneumonia, which is what NSIP stands for, is a particular pattern that we see on a CAT scan. People who have an NSIP pattern can have a cellular pattern, which basically means that it looks more inflammatory, or they can have a fibrotic NSIP pattern that looks more fibrotic or shows more scarring. And the distinction between the two really comes down to how we think that a patient may or may not respond to specific medications. And so as a general rule of thumb, conditions that are inflammatory or cellular are more likely to respond to medications that treat inflammation. So our traditional immunosuppressants. Conditions that are more scarring or fibrotic may not respond as well to those medications and may benefit from treatment with medications designed to slow the progression of scarring or fibrosis. But it's not always that simple. And so even if a patient has a fibrotic NSIP pattern, if they have underlying myositis, their initial choice of therapy should be an anti-inflammatory. But again, this is more communication to the physician. Those patients still have ILD. It's more of us narrowing down our thinking and then framing our thinking around treatment. And so again, it's part of the confusing terminology of ILD where we're talking about the same thing, but maybe little nuances within the same thing. The next question that I get asked often by my patients is, do they need a lung biopsy? And so the short answer for most patients is no. And the reason why is that in the recent era, the use of these high resolution chest CT scans has allowed us to avoid a lot of biopsies we would have done in the past. Because again, remember I mentioned that when the radiologist reads the CAT scan, they're telling the provider who ordered it, this is the pattern of lung injury that I see. And then the provider is using that information to then narrow their thinking about what types of ILD cause this specific pattern. And so, for example, NSIP is one of the things that a pathologist, so someone who looks at biopsy specimens under the microscope, might identify if someone has a biopsy. But it is still up to the doctor to figure out what they think caused that NSIP pattern. And so I think that a lot of people think that the biopsy makes the diagnosis. The biopsy really just gives us more information about the pattern of injury in the lung, but you still need to do your detective work to understand that pattern. Furthermore, in our patients who have a characteristic pattern on a CAT scan, the right presenting symptoms, and evidence of an autoimmune disease, that's enough to make the diagnosis. You do not need to go the extra step of getting lung tissue to feel comfortable with the diagnosis. And so the few exceptions to this would be if you think someone has a particular diagnosis and they're not responding the way that you would expect, that would be a time to go in and get more tissue. Or if you're worried about something else. And the big something else's that we worry about would be an infection or cancer. And those would be times where you want to go in and get some tissue. And so typically when we do biopsy patients' lungs, we're going to do that in one of two ways. The first is either through a bronchoscopy, which I've shown a picture of a bronchoscope here. This is a lighted camera that we put down into that big windpipe, the trachea from that picture I showed you earlier. And then we go down and we either do what we call lavage, where we get cells to send and see if we see infection, or if we want to get a biopsy tissue, we take these little forceps on like a little alligator clamp, and we go out and we take a piece of the lung and then we pull it back to the scope and send that to the lab. And so this technique can diagnose some forms of ILD. This actually is not a technique that we would recommend if we thought a patient had myositis ILD. And so in those instances, the best choice for getting a biopsy would be a surgical lung biopsy. And that's through a procedure called a VATS, or a video assisted thoracoscopic surgery. And so they make small incisions in the chest, and then you can see here that they have their instruments going through those small incisions, and they're looking on the screen, and they see this image here on the right, which is in the patient's chest wall. This is the collapsed lung, and they actually take a piece of the lung and then they send it to the lab. And so again, this is if we think that tissue is needed, but I will reiterate that for the vast majority of patients with myositis, this is not necessary. Now, some of you may have had a biopsy, and again, that goes back to who was the first person to lay eyes on you. And so, again, that patient who comes in with very sick, with a rapidly progressive disease and a lot of inflammation to the ICU, they may not be thinking about myositis. Someone may not have sent the antibody test. They may not be looking for rash, or the patient's on a ventilator, they're not able to ask them questions or look at their strength. And so that patient may end up getting a biopsy, and then we see evidence of what looks like an autoimmune ILD, and then the tests are sent. And so there are times where this information is gathered at a rapid rate, but for most patients who are going to present to a clinic and who are able to express their symptoms and we're able to elucidate signs and symptoms of myositis, we are not going to need to go down this pathway. And so that's the evaluation. And so briefly about management. And so this part of my talk is intentionally vague, and that's because I'm not here to provide individual patient advice that would supplant your own physician. And so I'm just speaking generally about our approach. And I think the most important thing I can say about this is that this is really tailored to the individual patient. All patients are different. You've already seen from my prior slide that there's a lot of variability even among patients with myositis in terms of their risk for ILD, the rate at which their ILD progresses, and how they respond to treatment. And so this really needs to be tailored to you as the individual. And the things that we factor in when thinking about treatment really are what I've called the 3 A's here. So the age of your ILD. Is this something that's been present for a long time and is now likely to be inactive, or is this a new diagnosis? Do you have pretty stable symptoms, or are your symptoms getting worse over time? And then how severe is your disease? And so all of those things are going to tell the provider whether or not they need to give you treatment at all. Some people don't need any treatment. They just need to be observed closely, or if you need to be treated very aggressively. And so as a general framework, treatment really is going to involve one or more of these 5 modalities here. And so the mainstay by far of how we treat ILD in patients who have myositis is steroids. And usually it's going to be prednisone, but some people like other forms of corticosteroids, but some type of steroid. And we like steroids because they work well and they work quickly, but they're not ideal long-term because they have a host of side effects, which I could list off for a long time, but they're not ideal long-term. And so usually we're going to be adding another oral agent on that's going to be designed to treat patients long-term as we attempt to taper the steroids either down to what is the lowest dose a patient can tolerate or off completely, ideally in some patients. If those things are not effective, or if people present with very severe, rapidly progressive disease, we're going to reach for medications that we give through infusion. And so these are things like intravenous immunoglobulin or IVIG, rituximab, or cyclophosphamide. And then unfortunately, in patients who progress despite all of those modalities, we might think about referral for lung transplantation. And the choice of these agents, again, is very individualized. It's going to factor in a lot of things, not just your ILD. We're also treating you as a whole person. And so if you have a lot of joint symptoms or skin symptoms or muscle symptoms, we're going to try to figure out which group of medications are going to be best to target all of those areas so that we're choosing the least number of medications possible to keep your disease under control. And then throughout the entire course of this treatment, no matter where you are, we're thinking about supportive care. And so this was a slide that was prepared by one of our pharmacists here. I will just say that the bottom line of the slide, because it is a little busy, is that it can be sometimes difficult to get the medications that you need because most of the medications that we're using are off-label, meaning that they have not been FDA approved specifically to treat patients with myositis or patients with ILD. And so we sometimes have difficulty getting patients' insurance to approve the medications, but we have several avenues that we can use to try to get medication for patients. And so that should not be a barrier to you getting the treatment that you need. It just might require some additional work from your doctor and team to figure out how to get you these medications, but there are avenues to do that.
And Dr. Johnson, if I could, I would just like to add that we also have a financial assistance program for myositis patients that can also add to that assistance.
Oh, great. That's fantastic. That's good to know. And that's a great resource that you should take advantage of. And so the next thing I'll say is that medications are not the only part of how we treat patients. And so we as pulmonologists, we love pulmonary rehab. Pulmonary rehab is a monitored exercise program that patients go to 2 to 3 times a week. And it's great because they give you a third of the time dedicated towards education. And so techniques for conserving your energy, breathing techniques for if you feel anxious or like you can't catch your breath, logistics about your care. And then the other 2/3 of it is literally working you out. And so getting you on an elliptical, getting you on a treadmill or stationary bike. And they also do a lot of light upper body strength training, which is so important because these are the muscles in your back, shoulders, your chest that help you with breathing. And so if you strengthen those muscles, you can do a lot. And this has been shown to not only improve patients' exercise capacity, but also quality of life. And so really encourage patients to undergo pulmonary rehabilitation. And this might be separate or above and beyond rehab that was recommended for you if you have a lot of muscle involvement from your myositis. I think that both programs are great. And if you can do both, you should do both. It's fantastic. Your doctor's also going to be walking you, or they should be walking you to make sure that when you walk around, you don't drop your oxygen level when you walk. Remember my little graphic where I showed that part of the problem is getting the oxygen from the air sac to the blood vessel. And so if that doesn't occur effectively, we treat that by giving patients oxygen. And so that is a big part of our supportive care. And then finally, palliative care has gotten a really bad rep, I think, because people hear palliative care, they associate it with end of life care and hospice, which sometimes palliative care is a part of that, but that's not all that palliative care does. And so a really good palliative care team offers support to patients and their families. They can be very good at managing some of the more difficult to control symptoms like cough or breathlessness that can happen in our patients. And so I think the earlier that we use them as a resource for patients, the better. And
I
then
can
you
just
look.
add, Dr. Johnson, that I'm currently on in palliative care, and it has been a true blessing. So, yes, if anybody out there is listening, and you need that reach out to the palliative care team in your area, please. It's so beneficial. Thank you.
Mhm. And then I will this is my last slide. So I'll just end in saying that I recognize that I'm very biased because I practice medicine at a tertiary care hospital in a major US city, and not just any US city, a US city in the northeast part of the country where we're a few hour drive away from other major US cities. And so I do understand that many patients do not have the luxury of living close to a major university hospital, which might be the source of expertise. And I also understand that it can be a big expense for patients to make the trip to these places, and that there's a lot of frustration for patients in coordinating their care when they have to go between providers in their local community and at a specialty hospital. And when you have a complex disorder like myositis, where you have multiple specialists following you might have a pulmonologist, a rheumatologist, a dermatologist, and that they may not always speak to each other in a way that's effective. And so my first advice to you is that I do think that if you have ILD or are worried that you may have ILD, that it is important to at least seek consultation with someone who has expertise in ILD. I don't think that you need to follow with that person forever, depending on the severity of your disease or how chronic your disease is, but at least getting someone who thinks about this a lot to review your case, to make sure we're not missing anything, is very helpful. And a good place to go to find centers that have ILD specialists is the Pulmonary Fibrosis Foundation. They have a nice link in the patient area that gives you a list of all of the centers for excellence in ILD throughout the country. And again, I know it's easier said than done, but I do think that it's important, again, to have someone who thinks about this a lot, at least weigh in on your case. If you live a great distance away, a good model that I have used is to alternate care between an ILD center and your local doctor. I think it's important to have your local doctor stay involved in your care. And so if you can alternate visits between those two providers, that way you're only making the trip out to the big university hospital a couple of times a year, not every 3 or 4 months. That's very key. And then I think it can be difficult because the way that we model medicine, ideally someone's primary care should be kind of their main home base, and that person is communicating with all the different specialists. But we all know that it doesn't always work that way. And so I think that if you can identify one person on your team that really will be the champion to communicate with others, or at least make sure that the key players are communicating, that can go a long way for you. And so I spend a lot of time on the phone with rheumatologists in the community where we're co-managing patients. And I don't mind that. That's part of my job. And I think that that makes the patients feel very comforted to know that I'm communicating with their local team and that they're being looked at as a whole patient, and that each of their providers knows what the other is doing, and that we're not giving mixed signals or making recommendations about treatment that may conflict with other things. And so, again, I recognize that that's easier said than done, but I think that if you can find a way to identify the person on your team that is best at communicating and get that person to bring everyone else in the fold, that would go a long way to improving your care.
Exactly what we talk about here at MSU is communicating with our doctors, how to always work on building that relationship, because it is so important. So thank you for acknowledging that.
Yes, and so with that, I'm going to stop sharing my screen and I'm going to take your questions.
I know that you're you've got your rush from time. You have a 2-hour hard stop, so we'll get right started. There's only a couple left. You answered a lot as you went through it, so thank you for that. It was an excellent presentation, and I love the layout and the formatting. It was easy to just keep focused on, so thank you. So Hillary has a question talking about her lung pattern has a quote unquote glass pattern. Could you explain what that is? And
Right. So ground glass is a term that the radiologists will use, and it's pretty non-specific. And so basically anything that fills that interstitium, so that area on my little cartoon, can cause a ground glass pattern. So you can see that if someone has fluid in their lungs, so pulmonary edema. You can see that in people who have certain types of pneumonia, and you can see it in patients who have ILD. And a patient where you think you're seeing that ground glass pattern due to ILD, the presence of ground glass is significant because that is usually one of those more inflammatory patterns, right? And so those are the types of patterns that we think will respond very favorably to immunosuppression. And so I don't want patients to have ILD, but when I see ground glass, I get a little excited because I know that there's the potential that if I get a patient started on treatment early and an effective treatment, that I can not only potentially stabilize their lung function, but potentially recover lung function. Because inflammation generally is a reversible form of lung injury if you catch it early. And so if you treat someone early who has ground glass, you could potentially resolve a lot of that ground glass. And so again, you have to put what you see in context, right? But if you think that ground glass is due to ILD, that person generally should respond to anti-inflammatory medications.
excellent. And in that explanation, you answered the other question as well. So talking about can you recover? Can your lungs get stronger and better with, in this case, the question is about exercise, but like you mentioned, maybe like the combination, if you have the pulmonary rehab, are there, typical like at-home things people do to help work on that?
I think so. So some of my patients, people with myositis can present it at different ages. You guys probably know that there's kind of a bimodal, right? So we can see it in people who are young and in people who are older. And so, I have some patients who are in their 20s and 30s. They don't really want to go to pulmonary rehab because a lot of patients in pulmonary rehab, quite frankly, they're going to have COPD or other things. They're going to be older. And so if you're 20 or 30, you might not feel comfortable because you're going to be the youngest person there. You're definitely going to stand out. Although I have to tell you that I definitely do have people who are in 20 and 30s who still love their pulmonary rehab, but it's going to be a different environment. And so, I do have patients who are very motivated. They can do the exercises at home. And so if you are motivated and you can do it at home, just any type of regular exercise program. And usually what I recommend is that you're doing something that gets your heart rate up and you're breathless enough that you can have a conversation, but it's slightly uncomfortable for at least 30 minutes, 5 times a week, that's sufficient. And then again, those light upper body strength training to do that at home as well. And so if you don't have a pulmonary rehab program close to you, you definitely can still do exercise at home. And it's so beneficial. I tell my patients all the time, like a broken record, there's so many things about your disease that you cannot control, but one of the things that you can control is what you do. And you have a lot of control over the fact that if you start regular exercise and activity, that can be so beneficial to your symptoms, your quality of life, and we can see improvement in your lung function. And so exercise.
It's so interesting when that news came out that, exercise actually helped myositis. For so many years, we were told, don't exercise, it's going to hurt your muscles. But Manuel, you had something to add, please.
Yeah, I just wanted to have a question related to this one. We have the pandemic, we have a lot of times the patients couldn't go to see the doctor. I wonder, for example, the pulmonary function test, is anything that the patients are doing that they can do at home, or is that totally naive to think that the patients can take some kind of pulmonary function measurement at home?
Yeah, it's a great question. So, we actually do have portable spirometers that we can give patients. And so, for example, our lung transplant group here, they gave all their freshly transplanted patients spirometers to take at home. that information gets transmitted from the home machine to us to evaluate in real time for changes. And so, I don't think that we have enough sophistication to do that yet widespread, but I think it's coming where we're going to be giving patients spirometers and having them do their own breathing tests at home. And then we're going to be recording that information in real time so that we're not just doing this every 3 months or so, we're doing this every day. And we're looking for little micro patterns or changes that might tell us really early on when someone's starting to have a flare.
That would work for clinical tests as well in the future, hopefully.
Yeah, absolutely.
Yeah.
Thank you so much. It's an excellent question. Let's see, anything else that you guys want to add? I know you only have 2 minutes. Let's see, what other questions? Typically, financially or with insurance, does palliative care provide for ILD specifically?
Oh my goodness. Yes, definitely.
Awesome. I think a lot of great news has come out of this, and I saw some comments here. There's good news because we can understand better, and we, like you said, there's ways that we can do for ourselves, like exercise and these pulmonary things. So I just want to thank you so much for all of this valuable information. I'm going to have to rewatch to take it all in, but it's so appreciated. Manuel, Lynn, do you have anything you would like to add at the end?
I think that was wonderful. We certainly learned a lot, and hopefully everybody in the audience as well. So that was a great use of the last 60 minutes. Thank you so much.
Very informative. Best that I've heard.
Yes.
Yes. It's
My pleasure. My pleasure.
Thank you so much, Dr. Johnson, and we welcome you back anytime. We'll be in contact for sure. So can't hide from us now, right?
Thank
Thank you. And thank you to everybody who attended today. We do appreciate your support. Please enjoy the rest of your day and look forward to seeing you soon. Take care.